Good morning, everyone, and thank you for joining us this morning for our webinar on speech and swallowing. We are really excited to have Ashleigh here with us today. Thank you so much for taking some time out of your Saturday to give us a little presentation. We really appreciate it. A couple of housekeeping things before we get going. The first, over on your control panel to the right of your screen, you'll see a little drop-down menu with some handouts. Some of those handouts are a resource page from Ashleigh on speech and swallowing that you can download. We also have a full list of some available programs from PAR, including some other upcoming webinars. Those include, we have one on vision coming up, we have one on DBS, kind of runs the gamut. So take a look at those, register for those, and we'll be having those throughout the month of April. It also includes some additional exercise resources that you can find online, and those range from being free to having a 30-day free trial. So while we're all dealing with this situation, we can still keep active and everything. PAR is also offering some online classes. We do need a waiver for that. So if you don't have a waiver form from us already, that is also in your handouts that you can download, fill out, and send back to me. You should have my email address. It's ecussler@parkinsonrockies.org. So feel free to send that over, and I'll give you the link with all of our exercise classes that we have available through the Parkinson Association. So with that, I think those are all the housekeeping bits I have. We'll have some Q&As at the end, and there are a couple different ways. I'll go over that when we get there. But until then, I will hand it off to Ashleigh.
Great, thank you. Hello, everyone. I'm Ashleigh Lambert. I'm a speech pathologist in the Denver area. And I have to say this is a first for me. I'm getting to do a presentation on speech and swallowing while wearing my house shoes. So certainly we are all adapting and changing with our times. And I just want to thank you guys for being here, and hopefully you're getting to be in your comfy clothes as well. Before we get started, you should be able to see my screen now. I also wanted to let you know you can raise your hand and ask questions and send chat messages. If we're going over quite a bit of information, speech and swallowing has a lot. So if there's something in the moment that you have a question about or want more information about, please feel free to chime in. I'm happy to answer those questions. So I just want to make sure you guys can see my screen okay, and we'll get started. Oh, see, I gotta learn how I can use my, there we go. So that's me. Just a couple disclosures. I do work for a company called SpeechVive. We're gonna talk about them in a little bit. So I just want you to know I do work there. I'm also vice president of the Young Professionals Board for the Parkinson's Association of the Rockies. So, which I'm happy to volunteer with PAR any chance I get, and love what they're doing there. So first off, why should I see a speech language pathologist? A lot of times we think of speech language pathologists as working on the R sound, or working with kids that stutter, playing games and getting stickers. We definitely do that. Speech pathology is a really broad practice. We work with birth to death, the entire age range. So in addition to working in schools, you'll see us in the hospitals. You'll also see us in outpatient rehab and skilled nursing and assisted livings. I've spent the last 18 years working with the neurogenic population, really on Parkinson's, Alzheimer's, dementia-related diseases. We work on, really what I tell people is we work on brains through lungs. So it's the cognition, speech, language, swallowing, and that breath support. So in Parkinson's disease, what are we up against when you come and talk to an SLP? What are we going to be thinking about the entire time? We know that there are changes in motor planning, in sensory integration. There's changes in muscle control and weakness. And then there's also cognitive changes. So everything we're doing, we're going to look at through that framework of what are we working against and what can we maximize. So as we go forward and talk about both the speech side and the swallowing side, you'll kind of hear that theme come up. Why are we talking about speech? about 90% of people with Parkinson's are going to experience some speech changes as part of that process. The overarching diagnosis for those speech changes is hypokinetic dysarthria. We'll talk a little bit about what those symptoms are, and we'll have some examples as well. Less than 5% of people with Parkinson's disease are actually referred to speech language pathologists. So that's something to keep in mind as we're talking today, and you're kind of inventorying what I'm saying and bringing up. You know, think to yourself, okay, is this something I'm seeing? Is this something I need to be aware of? It's you shouldn't expect your doctor to be the first one to bring this up. You're going to need to bring it up to your doctor. As you know, there are a wide range of symptoms that you and your movement disorder specialist are addressing, and you really, you know, those twice yearly visits, it's a lot to get in. So if this is something that's concerning you, you can bring it up. And then also the other side of speech is it's our way of communicating and connecting to one another. When your voice isn't as efficient for you to use, it makes that communication shorter, a little more effortful, more difficult. It can change those relationships you have. It can also be harder for you to advocate for yourself in that medical setting when you feel like it is so effortful to talk. So this is something to be aware of and really advocate for yourself and your loved ones. So remember, we talked about, we got to know what we're up against. Here is everything that's involved with speech from an anatomical standpoint. We're going to start down there at the diaphragm. We know that we contract and relax that. That helps expand the lungs to fill with air to give us enough air to then go up the trachea to the larynx, which is that voice box. Those vocal folds are going to vibrate. And then up above that voice box, the oral and nasal cavity, the organs and body parts in there help shape the sounds that are coming out to enunciate clearly. A little closer view here, we've got that windpipe, which is the trachea, and the vocal folds. Over on the side, those ovals, that's a top-down look at those vocal folds. They have to come together, and air moving up and over them makes them vibrate. So we're going to look at that as well. And then we're also looking at those articulators. We've got the soft palate that comes up and can close and close off the nasal cavity or keep it open for sounds that we need to go through the nose. We've also got the tongue, we've got the lips, and we've got the jaw. So all of those help make our sounds clear and shape those sounds. Other things we need to address when we're talking about speaking is communication's more than just making sound. It also requires cognitive skills and flexibility. You have to be able to think about what you say as well as how you're going to say it, and gauge how your audience is responding. Are you changing you're changing online as you talk, what you're saying, how you're saying it, and to whom you're saying it. You're filtering out background noise and you're adjusting. That goes along with that sensory input. As well, we know that communication isn't just auditory. It's not just about what we hear, but it's about facial expression. We emote using our face. So we're also doing that at the same time. And then we're also changing the inflection and the rhythm of our speech to change the emphasis. And get our point across. So all of those things we're doing, as well as those motor functions of just making the sounds. So the common speech changes that we're familiar with that hypokinetic dysarthria diagnosis, really the hallmarks are the low volume, slurred speech, abnormal speech rate. For some it can be those rushes of speech, for others it may be a slowing. We've got, for some, stuttering, shortened phrases because of some breath support issues, not being able to get out as many words per breath, and then also that lack of intonation and expression. So just as an example, let's see if I can go back. Listen, I think everyone's familiar with Muhammad Ali. This is a video from the Oprah show when he was later in his diagnosis, really it gives some of those hallmarks of hypokinetic dysarthria.
Means people who don't really know much about me, to tell them more about who I am, to understand more about the.
So on there, you could also hear you could also see not just those hallmarks of his voice, but really that masking, that lack of facial expression that makes it difficult to also decode what he's saying. So we're all thinking to ourselves, okay, where do I fall? What have I seen? You may not see it. It may be your care partner's seen it. And we'll get into a little bit of that as well on some of the sensory. Actually, we'll talk about that real quick. So we know that there's sensory changes. There's actually been studies done that have shown that people with Parkinson's disease do not perceive their voice and speech changes as severely as their listeners do. So this is that common complaint I hear often where we have a person with Parkinson's disease and a care partner, and we have a person with Parkinson's disease saying, my spouse isn't listening, they need hearing aids, they just don't want to listen to me anymore. And we have the care partner saying, I can't hear them regardless of what I do. And so we've got kind of a disconnect. So it's really understanding that there is a sensory side to this too, and you may feel that you're loud enough and speaking very clearly, but perceptually you're not. So when should you talk about speech to your doctor? Really, the sooner the better. We know with Parkinson's, the sooner we can address an issue and start getting that therapy, just like physical therapy, doing the exercises, as soon as we can work on those motor systems, the better. It also follows those motor planning underpinnings of use it or lose it. So we want to get in there early, we want to get in there hard, give you the tools, not just exercises, but tools to adapt and change so that you can have quality communication as long as possible. And then again, I just want to reiterate, you will notice these changes, and not just you, your care partner and your conversational partners. You're going to notice these changes before your doctor does. I'm sure if we were in the same room and I could get a show of hands of how many people, when they go to the doctor, they're having their best day, or they're walking better than typical, they're talking better than typical. That's pretty common. And when that doctor only gets to see you twice a year, it's really up to you to let them know what your priorities are and what you want to address. So if speech is at all something you're concerned about, you need to address that in that meeting. I'm going to keep going. If anybody has questions, feel free to type them in or let Elena know through chat, and I'm happy to answer them. So what can I expect from a speech evaluation? I know for a lot of us, we've never been to a speech pathologist before, and that's kind of weird. So I wanted to let you know what's involved. Just like going to the doctor, the first thing we're going to do is a pretty thorough medical history. And then we're going to talk with you about your specific concerns about your speech and voice. This is something that before you go in, it can be really helpful to think about that. Think about what are my goals for my communication? How will I know if I'm meeting those goals? What will that look like to me? For example, that might mean thinking of situations where communication is a struggle. For a lot of people, that could be on the phone or in the car. I know I hear that a lot. It's really hard to understand them when we're driving together and I'm driving and there's the road noise and my loved one sitting next to me and I can't look at his face. That can be really hard. So how are you going to know when your speech goals are met? It might be, I want to be able to talk on the phone and not have to repeat myself or I want to be able to talk in the car and have a conversation. Or it could just be, you know, I really get tired when I'm talking and I give up. And I don't want to do that anymore. What I have to say is important and I want to be able to connect. All of those are great goals and something that you should bring to the table to let your speech pathologist know what your expectations are and where you want to put that primary focus. So you're going to talk about that at length. They'll also do a cranial nerve and motor speech exam. That's going to feel a little unusual. It's going to involve really looking at how the musculature moves and coordinates. So you're going to do interesting things like alternating motor movements, where you're going to say things like padaka, padaka, padaka as fast as you can. You're going to make unusual faces like a big smile and then into a pucker. And you're going to raise and lower your tongue and stick it out. And they're really going to be looking at how everything's moving. They also may do an instrumental exam, and I've got a video of that I'll show you at the end. And typically what that would be is a fiber optic endoscopy exam of the larynx, where they're actually going to put a camera down your nose to look at your throat, and I'll show you what that looks like. We'll most likely be recording voice samples. They may discuss a possible referral to an ear, nose, and throat doctor. Some of the treatment protocols that we utilize in speech therapy require clearance by an ENT before we can start. They're going to do screenings of your swallowing and cognition. Remember, we're brains to lungs. So anytime you're in front of us, we're going to look at everything. We'll also then discuss all the results of those exams, talk about all the possible interventions that would be appropriate for you, and then develop a treatment plan as a team. That team piece is key. If your speech pathologist is telling you what these options are and asking for your feedback, you've got to be honest. You've got to let us know what's possible and what's asking too much. What you're going to see in a minute is some of these treatment plans are pretty intense and require a really high level of commitment. And it is absolutely okay to say, yes, I'm ready to do that, I'm gung-ho, or you know what, that's not going to work for me right now, and here's why. Let's talk about all the other options and explore everything and find something that works for everybody. So I just want you to make sure that you know you are not just on the team, but you're the primary team member, okay? So I've got that video. I'll show you kind of what that fiber optic endoscopy looks like.
Hey guys, this is Matt Ramsey with the Active Fire Voice Studio, and I'm getting scoped by Dr. Whitehead of Austin ENT.
There is a camera that goes down the nose. They're going to have you talk and make sounds and actually see the vocal folds vibrating and make sure that there's no other type of abnormality down there that would cause problems beyond what we're expecting to see with hypokinetic dysarthria. All right, this I'm actually going to come back to. So we are moving now into the interventions that are research supported for Parkinson's disease. I've limited these to really the interventions that have some good published evidence supporting them. So certainly if you go onto Google and you type in speech and Parkinson's, you may find some other things listed as well. I wanted to really keep it limited. So we're going to talk about a few things. The first one is behavioral approaches. That's more the coaching, kind of traditional therapy model. And that would include ones I'm sure you've heard of, LSVT Loud and SPEAKOUT. And then we'll talk about some technological approaches. These may be lesser known. So we've got amplification devices, alternative and augmentative communication devices, and then a device, SpeechVive, and that's that company I work for, and we'll talk about that too. I'm going to go back to my other slide. So the primary target we use when we're addressing hypokinetic dysarthria, that Parkinson's speech and voice in speech therapy is loud. And why are we addressing loud? When we talked about, it's not just volume, it's slurred speech, it's rate, it's fluency, it's short rushes of speech. Why do we only target one thing? So the reason why is because what the research has shown, and really when we've looked at kind of the neurological changes that are happening and how they impact motor planning and learning, what the evidence supports is by focusing on a single target, we can then maximize. So when I say loud, it's just like me saying, start your car. You and I know how to start a car, but that doesn't mean I know all the parts that go into making that car start. No one, I can't be expected to understand that or explain it to you. I just know when I put the key in and turn the ignition or push the button, it turns on. Same thing with loud. When I tell you to be loud, what you're actually doing is taking that deeper breath, it's expanding your rib cage, it's pulling that diaphragm down, it's making that deeper breath is using physics to then help your vocal folds come closer together, they're vibrating better, that voice, that sound is coming out louder. It actually helps then increase the range of motion for those articulators, those body parts that shape sound, and we hear a nice, louder, clearer sound. It also can help slow our rate, and there's less evidence on the disfluencies, but for some it can help with that as well. So if we target one thing, being loud, we're actually working on all those underlying systems together. So one way to do that are those behavioral approaches, and that's that coaching model. That's you sitting across the table from me, your speech pathologist, and we're going to work together as a team. It's there's some things that are required with this. It requires you to multitask. You're going to learn, we're going to put you incrementally through a system where you're initially going to have you're going to work just on the sound level. You're going to say your ahs and you're going to get them loud. And then we're going to work on the single syllable to word length, and then we're going to transition to phrase length, and then we're going to go to reading and then conversation. So you and I are going to be practicing. So really they're starting, it's trying to start you at a easier level and then transitioning to that more complex multitasking during speech. So remember, we're already multitasking because we are thinking about what we're going to say, how we're going to say it, who we're saying it to, eliminating distractions in our environment. And now we're going to think about being loud at the same time. So that's a part that can be difficult and requires that high level of practice. And again, motivation too. So that's on there. You've got to be motivated. This is also, depending on if you're doing LSVT or SPEAKOUT, you're going to be expected to come to therapy 3 to 4 times a week for an hour-long session one-on-one with your speech pathologist for 1 month. So that's 12 to 16 hours of therapy in that first month. Then on the days that you're not in therapy, you have to do homework. So you're going to be practicing that louder voice in a very incremental and prescriptive way, with the goal of it getting to transition to feeling more normal and automatic. You're doing that every day during that month of therapy. And then the protocol requires that you continue that home-based exercise program every day, even after you've graduated speech therapy. So this would be no different than going to physical therapy or starting an exercise program. Again, we know you use it or you lose it. So certainly you can get that nice voice that you're wanting. You've hit your goals. If you don't maintain that, we're all going to expect it to decline again. And then one difference with SPEAKOUT versus LSVT Loud is the SpeakOut research has integrated a once a week loud crowd. After you graduate from your individual therapy, you go into a loud crowd. So an hour a week, you're meeting with the speech pathologist in a small group, and you're practicing those tools and strategies that you got during therapy, and kind of have an accountability group for that. I know LSVT Loud has also implemented a Loud for Life program. I believe it's more of an optional program at this time. But so that's what's available as far as the therapy approaches. I was able to, got a video here. Samantha Landry is the speech pathologist that created the SpeakOut program through the Parkinson's Voice Project. She's actually been doing Facebook Lives since the stay-home orders with anyone that's gone through the SpeakOut program. So I actually have a video to kind of show you LSVT Loud and SpeakOut. While there certainly are differences, some of the principles are the same, and what the practice looks like it is similar. So this is kind of, I edited it. It's a 38, she's doing about 30 to 40 minutes. I think 3 days a week she's showing proctoring exercises. So I cut it down, but I wanted to give you kind of a good cross sample of what that session might look like. Something to keep in mind, this is the exercise sessions for people that have already graduated. So she's not doing as much explaining. And again, I cut out a lot of it, so just to give you an idea.
So, me, my, up and over, and we're holding it for about 10 seconds. No need to hold it longer than that. Let's go. We are busy filing our taxes before the deadline. Say it again. There are some exercises that talk about naming the steps for different activities, okay? I know that a lot of people like to skip this exercise. They don't like it, or they think it's kind of, I don't know the word, elementary. I think it's too simple. But we've got to make sure we're doing it the right way. The whole purpose of the exercise, of going through the steps of what you do when you're doing a certain activity, you're supposed to be very specific, and we're working on speaking out while we're organizing our thoughts. So when you go through this, here we go with intent over the tennis net. Gula gun ga ga. I know it's silly, but who cares? Let's do it again. Gula gun ga ga. One more time. Gula gun ga ga.
All right, so what you can see there, again, she's taking you from that ah sound into, shorter words, counting, phrases, organizing your thoughts while trying to use that louder voice. And then she also did some phrases at the end. So that's what that would look like. So that's kind of the nickel tour of the behavioral speech therapy approaches. We're going to transition into the technological approaches. If you guys have any questions about SpeakOut, LSVT, what's going on with that, let me know. Something I should let you know too, both LSVT and SpeakOut are additional certifications that are required of speech pathologists. So certainly you're going to find speech pathologists that are not certified in one or the other or either. It is within our scope of practice, even without those certifications, to address the speech changes associated with Parkinson's disease. So in no way does it mean that if you're referred to a speech pathologist that doesn't have those certifications, it doesn't mean that that speech pathologist isn't qualified. It just may be worth asking the question of, what's your experience? Have you, what have you learned about LSVT or SPEAKOUT? Are you certified? Why or why not? That's a great question to ask. But what I want you to know is, if you do not have a speech pathologist in your area that's certified in either one of those, that doesn't necessarily mean that they are not qualified. Okay. All right, so we're into technology. We're going to address 3 different types of technology today. The first one is the personal amplifier. I put a picture over there and I've got a video showing it as well. Really what this is the belt-worn or tabletop placed speaker, and then you're going to wear a headset with a microphone on it. This is kind of what you might see a tour guide wearing to amplify their voice. So some really good benefits. You want to be louder, you turn up the speaker and you're louder. It's pretty plug and play. The only time you wouldn't have your louder voice is if your battery ran out, and that's pretty easy to fix. This can be a great option when it's just volume that is a concern for you. It's going to increase your speech volume, but it's not going to do anything if there's issues with clarity, rate, or fluency. It's just going to make the sound coming out of your mouth louder. So that can be a disadvantage often with hypokinetic dysarthria, because we're not just working on that louder voice, we also want to work on that clarity side and the rate. Also, unlike the behavioral interventions that are working on your physiological changes, releasing rigidity, working on how those vocal folds come together, helping you recalibrate that sensory side of how do I sound to myself and others. This isn't doing any of that. This is literally, you've got a speaker in front of you and you're turning up the dial. So as far as kind of therapy, that's not what this is. For some people love them, think it's great, because again, it's that plug and play option. For others, they do feel that it's a little large and intrusive. So it really is up to you. These are readily available on Amazon. When Radio Shack was a thing, I think most of us on this are probably can remember that. They were really easy to find there. But Amazon has a number of these. You can spend anywhere from $50 to $500, and it has to do with the quality of the sound and the quality of that microphone. So I want to just go ahead and play this clip for you so you can kind of see what this does.
Timer? Sorry. So I'm going to stop whispering that. Maybe we'll save some marriages, who knows?
All right. So, so the reason he said save some marriages, this is a speech pathologist in Australia discussing that often when people are coming in with communication problems where they're seeing that friction is that husband and wife dynamic, which I don't know, I think we could probably take a raise of hands on that one, and I'm sure a lot of us have experienced that as well. So what you heard, he still had that whispered sound quality, but it did increase the volume. The next technology that we're going to talk about is called alternative and augmentative communication. They call it AAC for short. So there's a nice picture of it up in the corner. This is using a touch screen now with iPads and iPhones and other smart devices being readily available. These are a lot more common and can be an option. So this would be an immediate volume increase and easy to use. Now, I think I should have edited that actually, to be honest. What it's going to do is it's not going to use your voice. It's going to use the voice coming out of the computer. You'll be able to, you know what this is? This is, I apologize, I did not change the text from the amplifier one. So let me just tell you about AAC. So you're not going to, this is not relying on your voice at all. This is you inputting into the computer and the computer speaking the words. We're probably all familiar with Stephen Hawking and how his computer was his primary mode of communication. That's exactly what this is. This can be a great option for those of us who feel that our verbal communication is no longer sufficient. It can be, it's a little more cumbersome. Number one, you have to carry your voice around with you. You also are limited to the icons on the page. They are dynamic and they can be programmed. So there's some learning there as far as programming the device. And your speech pathologist would help with selecting and programming that device with you as a team. But for some people, it can be the best option. So I've got a video to show you also of how this would look.
There's off-the-shelf synthetic speech that approximates someone's voice. Hello, this is my voice. And then there's message banking. This is the main menu of all of your phrases.
Hello, my name is, what's happening? Hey, Sean.
So what that video showed was even more so, we have the computerized speech like what Stephen Hawking was using, but now there's also the option before the deterioration in your voice is so great that it's not intelligible anymore, to voice bank, where you actually pre-record phrases that they can then input into the computer system, and it's your voice coming out, preserving your identity, which is awesome. This gentleman has ALS. You can see he wasn't even manipulating the device with his fingers. He's actually using eye gaze. So this is a technology that is used across multiple diagnoses and can be the only means of communication for some people. All right, the last technological approach we're going to talk about is the SpeechVive. This is the company I work for. So this is an ear-worn device. What it's doing is really still addressing that loud voice that we're wanting through that behavioral traditional speech therapy approach, getting loud, that single goal that we know works on a lot of underlying systems and outcomes. But instead of looking at it from the coaching side, which we know can be difficult as far as the amount of time, the intensity, the amount of cognitive load it puts on your system of that multitasking, and then that just the motivation and buy-in to continue to practice every day and keep yourself accountable while having changes in the sensory side, it can be a lot. So research was done at Purdue University, started about 15 years ago, looking at, we know we want to get loud, what's another way to do that? And another way to do that is leveraging something called the Lambert effect. And the Lambert effect is our natural response that we all have to increase our speech volume, slow our rate, and enunciate more clearly as the ambient sound around us increases. So if you and I went into a loud restaurant, we automatically speak louder to be heard over what's going on around us. This is kind of that phenomenon you get when someone's talking on the phone in line at the grocery store. Probably not as much now because they're 6 feet away, so they're not right on you. At least they better be 6 feet away. But when they're talking on the phone and they're too loud and you can hear everything that they're saying, that's the Lambert effect. So we know that when you're somewhere loud, you're loud. Well, what if we just made your environment louder and no one else is around you. So that's what the device does. It's an earpiece. It's worn in just one ear. It plays sound in your ear when you're talking. That sound gives you just enough bump to increase your speech volume, slow your rate, and enunciate more clearly as you're speaking. So it's immediate, it's automatic, and it's a lasting improvement. It has the same outcomes as LSVT Loud and SPEAKOUT, but again, it's as soon as you put the device in your ear, you get those outcomes. It doesn't require that same high intensity therapy. It's really you wear the device. What your exercise is talking. Every time you talk, you're pushed into that louder volume, which is helping with the coordination of breath support and how those vocal folds are vibrating and making it efficient overall. So one of the outcomes that we've seen that's been published is your speech is louder and your phrase length is longer. So that's really that efficiency of breath support there. So I've got a video of this as well.
And,
What bothers you about your speech or your voice?
and then it's kind of no volume. And I guess because of the acoustic pneumonia, it's not, and my speaking is not clear. It's getting worse. When sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above.
Okay, Leo, so I am recording you again. This time with the Speech 5, can you just turn your head all the way that way for a moment, just so I can capture that in your ear? Yep, okay. And I'm going to have you just read that top paragraph of the rainbow passage, and you can begin.
When sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of light, white light, into many beautiful colors. These take the shape of a long, round arch with its path high above.
All right. So just to review, we talked about both behavioral and technological approaches to addressing the speech changes with Parkinson's disease. That's called hypokinetic dysarthria. Really, we're going to work on that single goal. That's not because that's the most important thing. That's because we know when we address being loud, we're addressing a number of other systems that impact clarity, fluency, and breath support. We know that the behavioral approaches are a high intensity approach. That's to really get that motor training involved and get generalization into conversation. We know that there are also technological approaches ranging from as simple as an amplifier you can turn up to as complex as a computer system that's been programmed to your voice or a device you wear in your ear. Do you guys have any questions I can answer for you as far as speech and voice are concerned? We're going to transition into swallowing. So feel free, if you have any questions, let us know. I believe there may be a way to raise hand or insert questions or just type a comment. I'm going to take a drink of water and then we'll move into swallowing. You can watch me swallow and hopefully I'll do okay. Hopefully I won't choke. All right. I didn't see any questions pop up, so we're going to go ahead and go on. So why are we talking about swallowing? Approximately 90% of people will have swallowing changes. So we said approximately 90% will have speech changes, 90% will have swallowing changes. Swallowing changes are called dysphagia. Something I should point out too that I didn't mention earlier. This isn't something where we're having a stepwise progression, and as we see other motor and non-motor symptom declines, that we can say, this is when you're going to start having a speech change at this level, and this is when you'll have a swallowing stage. It's not an early, late stage thing. It's individual to everybody. As you know, when you've met or had one person with Parkinson's, you've met one person with Parkinson's. Everybody's disease progression is different. So this is something to be aware of even early in your diagnosis. It's something to start talking about early on as well and getting that game plan in place. What are some complications with swallowing changes and dysphagia? I've had many people tell me, why are you talking to me about swallowing? I've been doing that my whole life and I'm just fine. Well, as changes occur with motor planning and musculature and coordination, we can see that food and liquid not going down the food tube, the esophagus, and moving into the trachea, the windpipe, and down to the lungs. When we get food in liquids in our lungs, that's called aspiration, and it can cause something called aspiration pneumonia. This is kind of that situation where you may have had someone you know that fell and broke their hip, they went into the hospital, they had surgery, they ended up with pneumonia, and then kind of had a decline from there. Most likely that was a pneumonia related to a swallowing disorder. And as they had that weakness onset from being in the hospital for a while, they became more susceptible to it. So aspiration pneumonia, that's a biggie. That's a biggie in Parkinson's. I've seen research that shows it can be the leading cause of mortality. About 40% of people will have some type of aspiration-related event that causes death in Parkinson's. Beyond that, it puts you at risk for malnutrition and dehydration, which can certainly complicate everything else. And another reason we're talking about this, you may have seen a theme with me on self-efficacy. You have a responsibility to advocate for yourself and to be the primary team member on your medical team. You have the opportunity to talk with your therapists and your doctors about your end-of-life planning as far as nutrition and hydration are concerned. So these are those conversations about feeding tubes, diet altering and modifications, and how you feel about that. And having those questions, asking those questions, and coming up with your plan before you have to implement it can be very helpful. So certainly good to have this knowledge. So just like for speech, let's go through a little bit of anatomy here. This is a cross-section of your head. So if I cut straight down the middle, this is what it would look like. We've got, I don't know if you can see my mouse, but we've got the nose, the lips, there's the chin and the bottom jaw. And then we've got in front there where that blue arrow is, that's the trachea. And behind it is the esophagus. So that first picture, a bolus of food, if you want to impress people, that just means chewed up food that's in a cohesive ball. So you've taken a bite, you're chewing it, it's moving to the back of your throat. Right now, your windpipe, that trachea is open because that food's still in your mouth. But what you're going to see as it kind of crosses the threshold into the back of your throat is the epiglottis, which is a little flap. It's going to close over that windpipe and protect your vocal cords and protect your lungs. And the esophagus will start to open up. It has a sphincter at the top kind of like a purse string closure, and it'll open up and allow the food to pass, avoiding your windpipe altogether. Then that epiglottis flips back and you can return to breathing. So this again, remember what we're up against. We've got that motor planning, we've got musculature and sensory. All of those have to be firing and working really well to coordinate this system. It's a really fast motor movement to get this done, and sensory movement or sensory integration side. I've got a video to kind of show you what this looks like.
Swallowing occurs in 2 stages, the oropharyngeal and esophageal stages. At the start of a swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis. With all airways blocked off, respiration is temporarily inhibited. As the upper esophageal sphincter relaxes, pharyngeal contractions drive the bolus into the esophagus. All
right, so who knew you were doing all of that, right? You've been swallowing your whole life, and that's everything that's had to happen to make it go. So we can also understand why, as we have neurological changes that impact sensation, because really your brain is proprioceptively aware of where that bolus is and making those motor movements in timing to it. But we also have to have good range of motion for those body parts, which should have looked familiar from what we talked about with speech. And they have to move with enough force and effort and range of motion to move the food back, but also close off the windpipe and move it out of the way and open the food tube, that upper esophageal sphincter, to let the food go down. The video actually goes on to even talk more about the esophagus, and there's kind of a wave motion that happens there. That can also be something, if you're feeling like you get some heartburn and things like that, that's absolutely something to talk with your doctor about, but we're going to kind of keep it to neck up. All right, so how will I know if I'm having swallowing problems? When should I talk to my, or what should I be looking for? You're eating more slowly. That can really be an indication that just that coordination isn't there. It's more effortful to chew and get that bolus cohesive. This didn't even talk about just the idea of the chewing motion and how you have to have enough muscle tone in your lips and your cheeks and your tongue to get that bolus cohesive so that it's not kind of just all over your oral cavity. If you feel like food's sticking in your throat, that's part of what we're talking about with that upper esophageal sphincter opening and that esophageal phase, where if food just doesn't feel like it's going down quite right, you're getting tired while you're eating, or you're just not enjoying food as much as you used to. You're having maybe some changes in that sensory side with the taste, or just fatiguing. It's taking longer and it's getting tired. You're noticing you're coughing when you're eating or drinking, or you're clearing your throat. You feel like something's in there, you just got to get out. Maybe that pills are more difficult to swallow. You may be experiencing some drooling, just losing the saliva out of your mouth. You're losing weight and you don't know why. That's a big one in Parkinson's. Not only are you losing weight because of all the excessive motor movements, but you could also be losing weight because it's taking so long to eat. You're not eating as much. When you're swallowing, it's not as efficient. Everything's building on itself. You may notice that you've started avoiding some foods because they're just too hard to eat. Certainly, if you are getting pneumonia, that could be a sign. It may be that you've had multiple bouts of pneumonia. Something to know too, I've had a lot of people say, I'm not worried about pneumonia because I get the pneumonia shot. Absolutely. Please get your vaccines. I think we're all becoming acutely aware of the value of vaccines lately. Aspiration pneumonia will not be prevented by the pneumonia shot. Aspiration pneumonia is, remember, it's from that food going into the windpipe or liquid, or even your saliva going into the windpipe and being in your lungs and getting infected in the lungs. Your lungs don't want that in there, and so they're going to try to get it out, and that's what that infection is. That's different from what a pneumonia shot will treat. That's more of a contagious kind, not from physically putting a foreign object into the lungs. Now, this last bullet, I should have made it really big and flashing. Research shows that less than 10% of people with Parkinson are going to experience these symptoms. But remember, 90% are going to have swallowing problems. So even if you don't feel like you're having a problem with your swallowing, you still could be. And it's still worth talking to your doctor about so that you can keep an eye on it. Some clinics now are even having people with Parkinson's go ahead and do some baseline swallow assessments to just see where we're starting. So that's going to lead me right into the next slide. Hopefully you're seeing I did a kind of a pattern between speech and swallowing. When should I talk about my swallowing with my doctor? I'm probably biased. Sooner the better. I'm always going to say that for speech and swallowing things because high incidence, 90% are going to have a change that needs to be addressed. And it's not going to be the top thing that your doctor's going to be looking at. It's not that motor symptom that they're looking at when they do the UPDRS. So if you're concerned at all, then it's time to talk to your doctor. Again, you're going to notice those changes before your doctor does, so it's up to you to bring it up. And again, just like we were talking about on that previous slide, this is an opportunity where you can ask your questions about end-of-life planning and get your questions answered so that you can make informed decisions between you and your loved ones about your wishes. So what can I expect from a swallow evaluation? Again, just like with a speech eval, we're going to ask you questions about your medical history and talk about specific concerns you have about your swallowing and eating. So again, come in prepared. Think about what's going on with my swallowing. Am I avoiding foods? Is there anything, am I taking a really long time? What am I noticing here? Again, we're going to do that cranial nerve and motor speech exam. We're going to ask you to make faces. We're really looking at how the muscles move and coordinate in range of motion. You're going to get a little snack. You're going to eat some foods and drink some liquids that are different textures and consistencies. And we're really looking at how all those phases of the swallow coordinate. You'll most likely be referred for an instrumental exam. One type of exam they have is, again, that fiber optic endoscopy, where they're actually going to put that camera down your nose again and have you eat and drink, and they can actually look in real time and see how where that food or liquid is going as you swallow. It lets us really look at the musculature, that timing, the range of motion, all of that. I'm going to show you a video at the end here. This is another type of swallow assessment called a modified barium swallow study. It's done in the radiology suite using fluoroscopy, which is a moving x-ray. And you eat and drink food that has a coating of barium on it, and so that it's easy to be seen. It's radio opaque, or it shows up on the x-ray, and you'll actually get to see it and trace it through the throat here in a second. Again, anytime you're in front of me, I'm going to look at everything. So I'm going to screen your speech and cognition. We're going to talk about any concerns you have there as well. After everything's done, we're going to discuss the exam results and all the available interventions that would work for you. You're going to develop that treatment plan as a team. Again, talk about what's realistic for you to do. You're the lead on your team. And then you're going to discuss your wishes for eating and swallowing again as the disease progresses. I know I'm probably a broken record on that. You can probably take away that I feel very strongly that you need to be the one making those decisions. All right, let's take a look at this modified barium swallow study. What you're going to see is kind of a black object move past the lips and chewing and swallowing, and hopefully you'll get to see that it goes down the back side of the throat instead of the front. So let's see if you can see my, oh, I can mark on this. Let me mark. So we're going to start here. Oh, I can't. Oh, it didn't do it. Okay. Anyway, take a look at the back of the throat. Here's the spine over here on the, when you're looking at it, the right side of your screen. And let's see if you can make this now. Oh, taking a drink, nice big drink. And there we go. And it went down the back of the throat. We didn't see anything go into the airway. So you would be doing something like that under X-ray. They'd have you eat and drink different substances and be looking at that timing, range of motion, and what's happening there. So how can I manage my swallow problem? Techniques and strategies are individualized and developed in partnership with your medical team. So I'm going to be in that radiology suite with you or doing that fiber optic endoscopy, looking at what's happening when you swallow. I'm not just looking at, is there a consistency that works best for you to swallow and stay away from your airway? Because we know if we thicken liquids or we soften food, we can change the dynamics of how we're holding it and swallowing it. But I'm also looking at physiologically what's going on. Do I need to work on increasing the strength at the base of your tongue so that it pushes farther back against the pharyngeal wall? Do I need to work on timing and sensory input so that your swallow starts quicker and it's more responsive? What do we need to look at together to work as a team? So there's not a one size fits all here where I can tell you, you should do this and it will always work for everybody. Because what may work for one person could actually make another person swallow less efficient or worse, or actually push food into the airway. So we don't want to do what our neighbor does. We want an individualized plan. Some examples of what that plan may look like. You may be asked to do some swallowing exercises. This can be putting a ball under the chin and doing some types of exercises to work on opening that upper esophageal sphincter. It could be using some different techniques where we're going to work on that tongue-based strength again, or the pharyngeal wall. We're going to work on a lot of things. It's, again, very individualized to the results of that examination that you had. Again, sensory integration techniques may be addressed. We know that we can actually make a swallow trigger faster by altering texture or taste. So we may be working on some of that. We typically don't work on just that in isolation. We're going to pair it with additional interventions. Compensatory strategies. We may see that there's a weakness on one side of the throat versus the other. So we're going to have you turn your head or tuck your chin or do some other types of posturing and maneuvers that change the respiratory pattern so that you can swallow and get that airway closed and out of the way. I mentioned briefly diet modification. We know if we change the viscosity or the texture of foods and liquids, it can make it a little easier to get that bolus cohesive. Remember, we talked about how it could be all over, easier to hang on to and kind of move back, and a little weightier to move along to the esophagus more efficiently. The last one, expiratory muscle strength training. I've got a picture of that there for you. This is a device that has really been, I don't know how long it's been around, it's been integrated into speech pathology practice for about the last 5 to 8 years pretty intensively. It was developed by a speech pathologist, and it's looking at, it's addressing another aspect that we need to, which is airway protection. So I didn't even really touch too much on that, but that sensory side, what happens when food or liquid doesn't go down the esophagus, but it goes down the windpipe? We've got our vocal folds, we've got our voice box here, and that's a great little tool that we use to make sound, but its primary function is actually to slam shut and stop food and liquid from going into the lungs. That's what it was designed to do initially. We just, as humans, created it, modified it to be able to use to make sound, to communicate as well, which is amazing when you think about it. But anyway, so it slams shut, it pops that food or liquid back out. That's that sensation of swallowing wrong or choking. We cough, 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 the whole, eyes watering, nose running, embarrassing in a public situation. That's what it's meant to do. But we know we've got sensory changes happening in Parkinson's disease. Studies have been done showing that when people with Parkinson's disease swallow wrong or a caustic substance enters the airway, there's less likelihood that they will cough. Studies were actually done inhaling a substance similar to like pepper spray, not quite as intense, but intense enough that typically you would cough and eyes watering, nose running. And we saw that 75-ish% of people with Parkinson's disease did not have a response. So we know we've got to work on that cough. We've got to work on the sensation side. We've got to work on the strength side. A lot of people are going to have kind of a puny cough. That's not going to get anything out of that airway. We got to get it stronger. That's where the EMST comes in, expiratory muscle strength training. Again, we're working muscles and we're working that motor planning side, getting it a faster response. When we have that initial trigger to cough, we want it to turn on quickly. So there's actually been some pretty good research done on this device. It's actually been shown to help speech a little bit as well. There's a new study that's almost done looking at EMST and SpeechVive together, and they have shown that together they actually have even better results than either one separately. What I like about EMST is it's something you can do at home. It's doing some exercises, blowing in this device. I think it's a 5 puffs 5 times a day situation, not too difficult and not asking you to come in to see a speech therapist as frequently. Certainly something to talk to your doctor or your therapist about and ask them if that would be an appropriate intervention for you as well. All right, so, I didn't give you any great information on what you can do right now to improve your swallow, but there are certainly things we should all be doing to increase our swallow safety overall. When we're eating, we need to be using good seated posture, 90 degrees to trunk to lap, and then knees to floor. So sitting up tall, eating in repose is not a great idea. Taking small bites and sips, being a little more aware of the size of the bites you take can be really helpful. Slow your eating rate down. This meaning having to eliminate some distractions at the meal time so that you can be a little more intentional and focused on what you're doing. Straws. I know a lot of us love straws because, especially with trimmer, straws can make it easier to take drinks without risk of spilling. They're harder to find now, but they're still around. They're great for that side of eating and drinking. They aren't a speech pathologist's best friend. Often when we use a straw to take a drink, what happens, if you remember in that video, it talked about the food going in the lips and then slowly making relative to the whole swallow, making its way to the back of the throat. We've got a lot of sensory input we're getting. Remember that, the things we're thinking about, sensory input telling us when, there's liquid in my mouth and I need to get ready to swallow. With Parkinson's, that motor planning time is a little longer, so more input is needed and a little delay. When we put a straw in our mouth, we're shooting that liquid to the back of our mouth without giving a lot of time for that input to happen. So it can be, it's a double-edged sword. Another thing, when we're eating and drinking, keep your chin neutral. So this is the whole drinking from a cup versus drinking from a soda can where you might tilt your head back. When you tilt your head back, what you're doing is making that trachea, that windpipe, nice and open, and that epiglottis would have to move even farther to cover it up. So you're kind of working against yourself. Another idea that you may have heard before is, instead of 3 large meals, moving to multiple smaller meals through the day. This can be really helpful when fatigue is playing into it, when you're just too tired to finish what you're eating. Really getting some nice nutrition and calorie-heavy foods in smaller increments through the day can help with that and really help with that weight side too. And again, as we talked about, those softer, more moist foods can be easier to eat and swallow. So certainly these are some things we can all take a look at. Again, your best bet is talk to your doctor about it, talk to your speech pathologist. If you're specifically worried about the weight loss as well, that may mean bringing a nutritionist or dietitian in on your team at the same time. I wanted to address drooling also. I know that this can be such a concern in social settings, and it's very common. So the first thing is to understand this isn't actually too much spit or saliva. It's actually the fact that you're not swallowing as often. Remember that sensory side. We actually have to feel when we need to swallow, and it's been dulled. So that saliva is building up in your mouth and it's coming forward instead of going back because we're not triggering that swallow and moving it to the back of our throat. So what can we do about it? Again, keeping your head level. Let gravity help you out, moving backwards instead of not downward gaze, moving forward. Reducing your sugar intake can actually help reduce saliva production. Things with more sugar in them cause more saliva. We certainly don't want to work against ourselves. Sucking on hard candy or chewing gum, I've got a lot of people that tell me that that works really well. The recommendation is that be sugar-free gum because we don't want to then add increased saliva production on top of it. I've had this suggestion as well, wearing kind of a sweatband on your wrist, that if you are having an issue with drooling, you can just discreetly take care of it. Another thing that can be kind of hard to implement, but before you talk, take a nice big swallow when you can remember, and that'll help as well, because I know a lot of times that drooling happens as you start speaking, you open your lips and have have concerns there. There are medications available to help address this by trying to dry up the secretions. There's medications, there's also Botox. There's a lot that you can talk about with your doctor. So again, what are you gonna do? Talk to your doctor about this, okay? The other side of it that we're not even gonna get into would be dry mouth. You can actually, take the good, take the bad. So dry mouth also can be an issue if you're having problems with dry mouth. Certainly we want you to work on hydrating, but you need to talk to your doctor because that can be a result of some medications, and there can be some changes that could be made for that as well. So what can I do next? Kind of wrapping it up. Hopefully you've got some good ideas of the signs and symptoms you're looking for. You have an understanding of what treatment would look like, things you can do today. But really, I want you to go and discuss your speech and swallowing concerns with your doctor. I know you're not going to the doctor. None of us are going to the doctor right now. None of us are going to the salon right now. None of us are going to anywhere right now. So if this is a concern you want to address now, absolutely you can, regardless of if you're social isolating or not, you can call your doctor. This is a common symptomology with Parkinson's disease, as you saw. This is something that often they will address over the phone and can make those referrals to you, to speech pathologists for you. Or I know a lot of the neurologists in the area, at least in the Denver area, are really aggressively implementing telehealth right now. That's available. And speech pathologists are also available via telehealth too. So even while we're social isolating, you can see your doctor and your speech pathologist in your house shoes. You're going to request that referral to a speech language pathologist. And then really, again, I want you to set the pace. Talk about what your goals are for your communication and your nutrition. What are you wanting to get out of this? This is, you know, you want to get the biggest bang for your buck. What's that going to look like? Then you're going to execute the plan. And remember, you use it or you lose it, just like with everything else. So execute that plan and keep going. Stay committed, and that will preserve that function as long as possible. So I know we had 2 hours, and I should have told you at the beginning. 2 hours of me talking about speech and swallowing is about an hour longer than I think I can handle. So I just wanted to leave time at the end for questions. Please feel free to ask me anything. There's also a handout. It has my personal contact information. You're always welcome to reach out to me. I am, again, a licensed speech pathologist in Colorado. I'm happy to help make referrals. It also has information about all the interventions we talked about, as well as a great resource through the Parkinson's Foundation. I don't know how sacrilegious that is to say, but they've got a great downloadable book completely about speech and swallowing and cognition. Really great resource. So all of that's available to you. So we'll open it up for questions and feel free to ask anything.
Okay, hi. Hi, so it doesn't look like we have any questions. There are a couple different ways that you all can ask questions. There is that drop-down menu to usually the right of your screen that you can type questions in, or there's the raise the hand function. If you go ahead and click that and raise your hand, I can unmute you and you can verbally ask the question for Ashleigh. So if anybody has any questions, feel free to use either of those two options and we'll get those questions answered for you. All right, so we have a question that on the availability of a recording. So you will be receiving a follow-up email in about a day that will come up in your email, and it'll have a recording of the session as well as a link to all of the different PDFs for the handout. So there will be a recording available for you. It'll also be available on our website. We can share it pretty widely, so feel free to share it if you'd like. We have another question. So the speech pathologist suggested a dry swallow after each sip or food intake. What are your thoughts?
So certainly, so that is absolutely a technique that can be used. Again, everything's individualized. So what that dry swallow is doing is that probably means that there's some residue that's hanging out in the throat above the windpipe and the esophagus. And so you're doing that swallow just to clear it and get it to move back to the esophagus. A consideration you have to have when you do that is that's 2 swallows per bite of food, which when we're dealing with fatigue is, you know, it's taxing. So we've got to kind of take the good and the bad and see if that's the right intervention. But absolutely, if that's what was recommended, that certainly can help.
Okay. All right. So we don't have any other questions coming in. We'll give it a couple more seconds, but in the meantime, I'll say thank you so much, Ashleigh, for spending your Saturday morning with us, and we really appreciate. Oh, we got another one. Can you suggest what can you suggest for people with nasal drip?
Nasal drip. That's a little out of my purview. I do believe some of the medications that would be recommended for drooling could help with nasal drip, because really what they're doing is drying mucosa. That would be definitely a doctor question, and they'll be able to help you on the medication side. As far as behaviorally, what you can do, certainly keeping a Kleenex handy and doing those wiping. You know, really, it could be that you're not sensing the nasal drip, so you're needing to just habitually wipe. It could also be that you're in a downward head position and we're not letting gravity help us out. We're going forward instead of backwards. So really looking at that posture. You know, with Parkinson's, we get kind of this curled over posture. So that's hurting everything we do. It's making it harder to walk. It's causing problems with drooling and nasal. We're also talking to our belly button, and we're swallowing in a more closed position. So that's where we can really pair nicely with PT or OT and working on that posturing. And that may mean even doing some bracing and stretching to get you up into that upright position. That opens up your breath support, that gets you talking and forward projecting, and then helps everything with gravity.
Okay, so the kind of follow-up question is, what about post-nasal drip down the back of the throat? I know.
That's that swallow not triggering, where, you know, I mean, we're all using fluid. We all have mucus. And so it's probably, I mean, certainly when we're talking about Parkinson's, we can't talk about it in a vacuum. I am having nasal drip issues right now because the pollen is going nuts. So is it that we have an allergy situation? Is it that we are having an issue where we're just not sensing it and swallowing it? Is it that thickening of the mucus, which is absolutely a legit thing? There's people that say that avoiding dairy can help thin it. Drinking more water can help thin it. Really just swallowing more, which is so hard to remember, can help. And then medication interventions to thin that mucus, dry that mucosa can help as well. This is where you're going to talk with your doctor. You're going to get involved together and figure out what works best for you. And believe me, I get it. You know, and that's that throat clearance. It's all of it. So I'm right there with you. I had to take my Claritin this morning. It's everywhere.
Yeah, I've been struggling with it as well. So I've definitely upped my allergy med.
Yeah, I have the little like pollen alert keeps buzzing on my phone and my watch every day. I'm like, I don't know what you want me to do about this.
Yeah,
I can't avoid it.
Yeah, definitely. Okay, so we've got a couple more little comments that we have here. One says thank you for the great information, and thank you for the clarity. Some other comments as well, but it looks like no other questions. We'll give it a couple more seconds to see if any other questions come in. But
I want to thank you guys. This has been great. It's certainly different presenting to a screen, but
yeah.
I love that we could all do it and no one had to get in the car to go anywhere. So it's my pleasure, and thank you so much for taking the time.
Yeah, thank you. So I guess if we don't have any more questions, we'll go ahead and wrap up the presentation here. And absolutely. I want to make sure that I mention again. Oh, go ahead.
Sorry, I was going to say, if you guys have questions later on, that handout has all of my contact information. Feel free to call or email me anytime.
Okay, it actually does look like we have another question. So are you still free?
Yep.
Okay, so This one's regarding diet. This person likes to drink milk, but they prefer skim milk. Is that problematic?
So certainly mucus thinning isn't my specialty. There are some reports that dairy can cause problems with mucus. I don't know what the mechanism is behind it. There are other reports that say that's bogus. So talk to your doctor is going to be my general statement on that. Certainly, I mean, milk has good calories for you. It can taste good. I don't want to tell you to avoid anything that's giving you pleasure. Talk to your doctor.
Awesome. Okay, so I think we'll go ahead and close it now. Just wanted to remind everybody that there are all of those additional resources in the handouts over to the right side of your screen in the drop-down menus. There will also be a link to those handouts in the follow-up email that will be hitting your mailboxes tomorrow around the same time. So if you've got any other questions, please feel free to email me or email Ashleigh, and we'll say thank you so much.
Thank you. Have a great weekend.
Bye, you too.